بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله. I would like to welcome you all in the second annual Congress of the Arab Thyroid Association. And this is the first day of this 2 days Congress. And this session actually will be about the thyroid diseases in children. And we have three eminent speakers in this session. Dr. Rasha Darif from Egypt, Dr. Abdel Hadi Habib from Medina, Kingdom of Saudi Arabia, and Dr. Najiya Atiya from Jeddah, Saudi Arabia. Start actually with the first session, the first presentation, which is will be on a very important issue, which is preventable, and that is congenital hypothyroidism, presented by Dr. Professor Rasha Darif. Dr. Rasha Darif is the head of Pediatric Endocrinology and the Obesity Unit in the Faculty of Medicine in Ain Shams University in Egypt. And she is one of the speakers who have national and international presentations, and this is one of them. So Dr. Rasha Darif will talk to us about congenital hypothyroidism, and we'll keep the questions till the end of this session. Dr. Rasha Darif, please.
First, I'd like to thank the organizing committee of the Arab Thyroid Association for inviting me. Thank you very much. I'm really glad to be with you today, and I'm going to speak on recent updates on congenital hypothyroidism. And let me open the scene by the story of this 3-year-old girl who came with mild pressure symptom. The girl presented with a midline swelling at the base of the tongue, with mild dysphagia, fatigue, weight gain, no bleeding or ulceration. As you see, the TSH was found to be high, the free T4 was low, antibodies negative, and thyroid gland was not palpable at its normal site. We did a thyroid ultrasound, and thyroid gland was normally located, but very small. It was hypoplastic. And the thyroid scan revealed 2 foci of intense uptake, one at the base of the tongue and another one in the submental area, while the uptake in the normal thyroid bed was very weak. So we are facing a case of dual ectopic thyroid at the base of the tongue and the submental area, plus hypoplastic utopic thyroid. And the suggested management here is surgical removal of the sublingual thyroid because it was causing symptoms. And we started thyroxine therapy because, as you see, the girl was symptomatic and she had clinical hypothyroidism. In the box on the right side, you can see a very long list of causes or etiology of congenital hypothyroidism. But the more important question is, which way shall we go? Instead of listing causes, it's very important to decide whether it's primary or secondary. And thanks to the neonatal screening program, who detects the primary congenital hypothyroidism very early in the first week of life. And thanks God, we do not see cretins nowadays. But unfortunately, there are missed cases that the screening program cannot detect in case of central hypothyroidism. And that's why it's really important to decide whether it's primary or secondary. The second question, is it transient or permanent? You can see here that 90% of cases of primary congenital hypothyroidism is permanent and need long-term treatment beyond 3 years and sometimes for life. Only 10% of the cases have transient hypothyroidism, and the treatment can be stopped by the age of 3 years. And that's why we need to reassess thyroid axis at the age of 3 years. And I'm going to discuss this later in the lecture. And I think based on answering these questions, we can put a treatment plan and we can answer the question whether it's a lifelong therapy or not. The cases of permanent congenital hypothyroidism is either due to a defect in the development, the thyroid dysgenesis, as you know, the dyshormonogenesis, or the hypothalamo-pituitary thyroid axis disorder. And unfortunately, there is a rising incidence of congenital hypothyroidism. And an important area of research is the genes associated with congenital hypo, whether the dysgenesis, dyshormonogenesis, or central hypothyroidism. And there are some genes associated with thyroid dysgenesis, and this is the list of genes. You can see this small and very coincised table published in 2011 in the Journal of Indian Society. You can see here the FOXE, NKX25, PAX8 genes. And the question is there any new genes? Yes. You can see on the left side a very recent article published in 2022 on the genetics of congenital hypothyroidism. And this is a very busy table in contrast, showing you the long list of genes incriminated in thyroid dysgenesis. So there are some recently discovered genes in thyroid dysgenesis, as you see, and you can see the box where the genes are listed. In addition, there are variable presenting symptoms with congenital hypothyroidism, congenital malformations, and associations. And this is a study that summed up the percentage, as you see here, in Italy, Brazil, USA, India, and in Egypt, my country. You can see a study in 2007, and you can see that Egypt has got the highest prevalence of associated congenital malformation. More than 70% of the cases have associated congenital malformations or abnormalities, in addition to congenital hypothyroidism. Included in the cohort of our patients at Ancient University is this case. And this is a 1-month-old male newborn whose parents are first cousin with a normal birth history. At birth, the baby had right guanal atresia and cleft palate. And the baby, for an unknown reason, skipped the neonatal screening program for congenital hypothyroidism. But the parents noticed at 1 month of age excess sleepiness and poor feeding. We did the thyroid function, and as you see, the free T4 and T3 were very low, and the TSH was above 100. There was athyreosis by ultrasound, and this was confirmed with no tracer uptake in the scan. And so the next step, of course, was genetic testing. And as you see here, we did genetic testing for this boy, and we identified a new homozygous FOXE missense mutation responsible for enhanced activity of thyroglobulin and TPO genes in this Egyptian boy. And what's interesting about this case is that there was loss of function of FOXE mutation. And what's known in literature is that this mutation and this syndrome that I'm going to show you is associated with gain of function mutation. And I think this is a clear difference between the Arab population and European population. And this article was published finally in Thyroid Journal. So this is the syndrome that I was speaking about. This is the Bamforth-Lazarus syndrome, and this is an autosomal recessive syndrome with loss of function, missense mutation in the FOXE1 gene, presenting with thyroid dysgenesis, mostly aplasia, cleft palate, spiky hair, guanal atresia, and bifid epiglottis, like our case. But as I told you, the gene, there was, in our case, increased thyroid gene expression rather than loss of function. And this is the story of a 10-year-old girl with a midline neck swelling. The swelling was noted at the age of 2 years, soft, cystic, not tender, moves with swallowing and tongue protrusion, no pain or discharge, and the girl was asymptomatic. The TSH was very high, T3 and not very high, it was high, 13. The T4 and T3 were normal and the antibodies were negative. And look how late congenital hypothyroidism could present. The girl is 10 years old. So she presented with subclinical hypothyroidism. And when we did a neck ultrasound, there was a thyroglossal cyst and the thyroid gland was not visualized in the thyroid fossa. The thyroid scan revealed a functioning ectopic thyroid inside the thyroglossal cyst and anterior to the hyoid. And there was absent uptake in the normal thyroid bed. And this was confirmed by CT scan as well. So we were facing an ectopic thyroid inside a thyroglossal cyst and infrahyoid. The suggested management is surgical excision of the thyroglossal cyst and tract because infection could happen. And in some cases, it could turn malignant, especially in the presence of ectopic thyroid. And of course, we started L-thyroxine replacement therapy. Of course, thyroid hormone synthesis is a very complicated multi-step process. Now, let's leave the dysgenesis and go to the dyshormonogenesis. And a lot of genes, as you know, are involved in thyroid hormone synthesis. Another novel list was proposed in Pediatric Investigation published in 2022. You can see another list of genes for dyshormonogenesis. And this is a quite common story, an 8-day-old neonate becoming asymptomatic, diagnosed on neonatal screening with a high TSH14. The T4 is normal and the thyroid ultrasound is normal. Now, to treat or wait, the question that we are asked by the parents. I'd rather wait at this stage based on the fact that the ultrasound is normal and the TSH is not very high. Now, 2 weeks later, the baby came back still asymptomatic. TSH jumped to 22 and the T4 is still normal, but less than before. Treat or wait? We have to treat at this stage, especially when the TSH is above 20. So the important question is, what is the cutoff TSH level to treat? And these are the European Society for Pediatric Endocrinology consensus guidelines published in 2014 on how to deal with infants with congenital hypothyroidism. If the TSH is above 40, you have to start treatment and do the imaging. If less than 40, withdraw a venous thyroid function test. If the free T4 is below the normal and or TSH is above 20, you have to treat and do imaging. And remember that thyroid scan is mandatory if not visualized, if thyroid is not seen by ultrasound, to exclude ectopia and to differentiate it from hypoplasia or aplasia, sorry. Now, what if there is a gray zone? The TSH is between 6 to 20, beyond the age of 21. We have to do retesting thyroid function after 2 weeks, in addition to imaging, thyroid scan, and or ultrasound. So we still have the controversial gray zone, 6 to 20. And in infants with mild subclinical hypothyroidism, when the TSH is ranging between 6 to 10, 72% resolve spontaneously. And the indications of treating such infants, if the TSH jumps above 10, or symptoms of hypothyroidism, or if there is frank dysgenesis like ectopia. And this is to save the brain because there are concerns on neurodevelopment and growth beyond the age of 1 month. Now, these are the consensus guidelines released in 2021, the ENDO, ERN, and the ESPE, European Society for Pediatric Endocrinology. This was in 2021. And what did the new guidelines add? There was a lot in common to the guidelines released in 2014 by the ESPE. But here is some new information. First of all, they used the same lab cutoffs. Again, above 40, you have to treat immediately. Above 20, you start and do imaging, and then you follow the algorithm. And you can see on the right-hand side the doses that we give according to age. And it was clearly mentioned to start LT4 treatment as soon as possible, not later than 2 weeks if you are sure of the diagnosis. What about imaging in patients with congenital hypothyroidism? It is strongly recommended to start LT4 before doing imaging studies. If the values, as we said, are above 40, use radioisotope scan with or without perchlorate discharge test or ultrasound. And remember that scintigraphy is the most accurate diagnostic test, but it's not done in every case. And if the cutoffs are very high, you don't need to wait for scintigraphy. You just start the treatment. But very important to do it if you cannot see the thyroid gland by ultrasound. The knee X-ray may be performed to assess severity of intrauterine hypothyroidism. You can see here the normal epiphysis and the very small epiphysis in babies with congenital hypothyroidism. In addition, scintigraphy and perchlorate discharge test can help in suggesting the diagnosis of dysharmonogenesis, whether it's iodide transport defect or organification defect or iodine recycling defect. And in the boxes below, you can see the suggested gene mutations for each case on how to think according to the diagnosis. What about monitoring treatment in congenital hypo? When? First of all, the sample should be withdrawn before or at least after 5 hours of the last T4 dose. And this was clearly mentioned in the guidelines. What are the targets that we need to achieve? TSH in the age-specific reference range and free T4 in the upper limit of the normal. And this is important for the brain development. And this is the schedule or the frequency of the sampling. After 1 to 2 weeks from the beginning of treatment, 1 to 3 months in the first year, every 2 to 4 months between 1 to 3 years of age, every 3 to 12 months until the end of growth, and finally 4 to 6 weeks after any change of the therapy, whether the dose or formulation. And there are some special situations when we need to answer this question, to do or not to do a second specimen. The first occasion is in babies with false negative neonatal screening result like premature, low birth weight, sick babies. A post-screening second specimen at 10 to 14 days should be considered. Down syndrome. It's highly recommended to measure TSH at the end of neonatal period because sometimes it develops by time. What about twins? The initial screening in affected twin may be normal, and a second screening in the same sex twins should be considered. The non-affected twin should be followed up later in life. So these are the special situations. Another question raised in the guidelines: when should genetic counseling be proposed? You can see this very busy list, but most important, if you have associated congenital anomalies, clear dysgenesis or dysharmonogenesis, history, consanguinity, deafness, or any other malformations. While preparing the lecture, I came across this interesting part related to the treatment. And this is a very recent article published in European Journal of Endocrinology on a very exciting topic, comparing L-thyroxine oral solution and tablet in the age up to 3 years of age, which is more effective and how does it affect the IQ? And the conclusion, as you see in these two tables, is that both therapies are effective. And you see here the TSH is more suppressed with oral solution significantly. So the oral solution has a higher risk of overtreatment in the first few months of therapy. And there was no negative effect on cognitive development. You see here a non-significant difference in the IQ scores between the two groups at the age of 12 and 36 months. Now, going to another rare category, the central hypothyroidism. Again, a very long list of genes being involved, either in isolated or panhypopituitarism types, or being part of a syndrome. And this is the story of a 1-month-old male whose parents are not consanguineous, born with a normal birth weight, length, and skull circumference. Screening for congenital hypothyroidism was considered normal because TSH was not elevated. And this is the tricky part of the neonatal screening. The baby started to develop progressive feeding difficulties, hypotonia, somnolence, and jaundice. We did the thyroid function, and this is what we found: low T4, T3, and TSH. And the rest of pituitary hormones were normal, MRI brain was fine, and thyroid ultrasound showed a normally located thyroid gland of normal size. So this was isolated central hypothyroidism. And when we did genetic testing, we found TSH beta gene homozygous single nucleotide deletion. And the baby was very well controlled on a small dose of thyroxine, 25 micrograms a day. The European Thyroid Journal published the 2018 guidelines of European Thyroid Association on management of central hypothyroidism. And here they mentioned a very important statement, which is very true if all of us will say it. Findings of central hypothyroidism are subtle. Yes, this is true. And they proposed some diagnostic findings. You can find it on the right-hand side table to suggest the diagnosis of central hypothyroidism. Most important is delayed growth, macroorchidism, hearing loss, positive mutations, of course, will find the diagnosis, other pituitary hormone deficiency, blunted response to TRH, and blunted nocturnal TSH surge. And this is the flow chart on how to think and diagnose central hypothyroidism. Collect personal and family history, evaluate other pituitary hormones, do a skull MRI, and look whether this is isolated central hypothyroidism or associated with panhypopituitarism. And you treat as appropriate on the same dosing schedule and monitor like in primary congenital hypothyroidism. This is the ETA guidelines, as you see. Of course, central hypothyroid patients need smaller doses than primary. Sorry. And the guidelines, the consensus guidelines of the ENDO-ERN, European Society of Pediatric Endocrine, raised a very important question. Do we need to add free T4 to screen for congenital hypo? And the answer was, when financial resources are available, it's better to measure free T4 when screening for congenital hypothyroidism in order to catch the cases of central hypothyroidism, in addition to the TSH. Because if you rely on the TSH only, you might miss, or you will miss, cases of central hypothyroidism, like the case that I showed you. And if the T4 is low, TSH is low, normal, or slightly elevated, the diagnosis of central hypothyroidism should be considered. In neonates with central hypothyroidism, it is recommended to start T4 after intact adrenal function. You confirm adrenals are normal. And if there is a coexisting central adrenal insufficiency, you have to correct it first to avoid adrenal crisis. What about re-evaluation of thyroid axis? Do we need to reassess the condition again? Yes. But 3 questions we need to answer. Who, how, and when? Who? Those with no definitive diagnosis of permanent congenital hypo in the first weeks or months of life, particularly in children with gland in situ, and those with presumed isolated central hypothyroidism. How? LT4 treatment should be phased out for 4 to 6 weeks or just stopped, and then you measure T4 TSH in 4 weeks' time, and some do it after 2 weeks. When? At the age of 3 years, to ensure that brain development is completed. And remember that reevaluation is not indicated if you have a clear diagnosis of thyroid dysgenesis, dysharmonogenesis confirmed by molecular genetic testing, or progressive rise in TSH with the need to increase the T4 dose. In such a case, you will not reevaluate and the child will continue on thyroxine treatment. And there are some scenarios on reevaluating the thyroid function. Either you will find primary hypothyroidism and you'll do thyroid imaging and genetic testing if possible. If central hypothyroidism is likely, evaluate other pituitary hormone and do genetic testing if possible. If the TSH is above the upper limit of the reference range, but less than 10, primary congenital hypo, and the 3-4 is just above the lower limit of the reference, central hypothyroidism, continue withdrawal and retest in another 3 to 4 weeks. And the final scenario is a child with no permanent congenital hypothyroidism diagnosis, and the gland is in situ, and he requires a very small dose, less than 3 micrograms per kg per day at the age of 6 months. You reevaluate at that time exactly. You don't have to wait. And this slide summarizes the genes involved in congenital hypothyroidism and the algorithm that we follow when thinking of the case of congenital hypothyroidism and the suggested genetic test that you do. So I think we need to think genetically because this will affect the diagnosis. And finally, the final step is the period of transition from pediatric to adult care. It could be really challenging because there is a risk of poor compliance in those patients and inadequate follow-up, leading to increased morbidity and poor educational and social outcome. So it's very important to handle the patients carefully during this critical period, and attention to transition should be paid for those patients. My final conclusions are primary congenital hypothyroidism is easy to detect by neonatal screening, but could be presented late childhood or with subclinical hypothyroidism, as the cases I showed you. Immediate start of correctly dosed LT4 treatment at the proper time is important, and follow-up are recommended to keep thyroid hormone in the target range. Timely assessment of the need to continue treatment and attention for neurodevelopmental functions are crucial. Harmonization of diagnostics, treatment, and follow-up optimizes the patient's outcome. Despite more than or around 50 years of neonatal screening for congenital hypothyroidism nearly all over the world, some important questions remain. The genetic etiology of congenital hypothyroidism, the assumed harm of subclinical hypothyroidism, the cause of the gradually increased incidence of congenital hypothyroidism with gland in situ. Further epidemiological and experimental studies are needed to understand increased incidence of congenital hypothyroidism. Remember that genetics of congenital hypothyroidism differs between Arab countries and Europe. And I showed you the very unusual genetic mutation that we found in the Egyptian boy with thyroid aplasia, cleft palate, and guanal atresia. And this was the reverse of the genetic mutation found in Europe. This is the Bamforth-Lazarus syndrome. And finally, remember that transition from pediatric to adult care is challenging. So I think we all agree that time matters a lot in cases with congenital hypothyroidism. And I really liked this quote. Success is simple. Do what's right, the right way, at the right time. It's really important to choose the time and to do it right. And finally, this is another nice quote. The bad news, the good news is you are the pilot. So we are the pilots of congenital hypothyroidism. We have to start treatment at the proper time with the proper dose and do the proper follow-up to get the best outcome in this really preventable condition. Thank you very much for your attention.
Thank you very much, Dr. Rasha Darif. And I just want to mention that this is the second annual Congress of Arab Thyroid Association. And my name is Dr. Abdulaziz Al-Tuaim. I'm the chairman of this session. And now we'll go to the second speaker. The second speaker is Dr. Abdelhadi Habib. Dr. Abdelhadi Habib is a consultant pediatric endocrinologist from Prince Mohammed bin Abdulaziz Hospital, National Guard in Al-Madinah Al-Munawwara. And Dr. Habib is also a member in the Arab Society of Pediatric Endocrinology, and he is a speaker in many international and national conferences. Dr. Habib will talk to us about hot topics in pediatric thyroid diseases. Dr. Habib, please.
To thank the organizing committee for inviting me to contribute for this meeting. I was given the task of highlighting hot topics in pediatric thyroid disorders over the last few years. And I think thyroid is very heterogeneous disorder. And I think looking at the literature and looking at our practice, I selected 3 areas in which some development, particularly in the clinical practice, took place in the last 3 or 4 years. Thyrotoxicosis, because there is a new clinical practice guidelines came out just last year, and there is a trial of novel therapeutic approach to treat children with Graves' disease in particular. Second area is the thyroid hormone transporter defects, and I will highlight the new hope in the treatment of this rare and difficult condition to manage. And finally, I will try to discuss with you the latest of what we think about the treatment of subclinical hypothyroidism. And I will start with this clinical scenario, and this is a 10-year-old girl with weight loss and sweating, and as you can see, she has prominent eyes and she's got tremor, tachycardia, together with mild goiter, and the thyroid function test clearly suggesting that she has thyrotoxicosis with positive thyroid receptor antibodies, confirming the diagnosis of Graves' disease. She was started on beta blockers, and the treatment options available for these girls is either to start antithyroid medication or to prepare her for radioactive iodine, or referring her for thyroidectomy. And in pediatrics, we don't really use radioactive iodine or thyroidectomy as a first mode of treatment or first treatment option. And we start normally with antithyroid medication. And with this, we have 3 questions to answer. Which type of antithyroid to use? Is carbimazole, metamazole, or propylthiouracil? And which regimen we're going to use, dose titration or block and replace, and how long we should treat such patients for. And I think we all know that the PTU is no longer in place due to the liver defect. And I think the best option for this girl is to start carbimazole or metamazole, depends where you are. But the question is whether to use dose titration or block and replace regimen. And there is a controversy, and this is just an online survey was sent a few years ago to the members of the British Society of Pediatric Endocrinology and Diabetes, and you'll be very surprised to find out that almost a third of these pediatric endocrinologists are still using the block and replace regimen. Yes, the majority of them use carbimazole, and around 80 or just over 80% treat these patients for a minimum of 2 years. And this is really showing you that there is a variation in the practice between pediatric endocrinology, not just in the UK, but I think over worldwide. Now, this is a very nice trial published just a few years ago, and it's basically comparing the block and replace to the dose titration of using the thionamide in young people with thyrotoxicosis. And as you can see, it's very randomized. You go to 2 arms, one treated with block and replace, the other dose titration. And if you look at the thyroid function test and the percentage of time of getting the TSH as well as the free T4 in range were both comparable. So there's no difference really between these 2 regimens in this aspect. However, if you look at the remission rates, clearly the dose titration has a higher remission rate, significantly higher at 26% compared to 15% in the block and replace. What was more important is that patients who were started on the block and replace regimen, they were more likely to develop, and in fact, they have 3 patients who developed severe neutropenia compared to none of those in the titration arm. And I think this is really the first data or first comprehensive data showing that the dose titration is superior to block and replace. You can still use block and replace, but in terms of superiority, dose titration is better. Now, so if we go back to the options for this girl, so we got carbamazole or methimazole, and it seems that the dose titration is the best for her. Now, how long should we treat her for? And this is an area of huge controversy. And I found this very nice systematic review published in 2021, and it's basically looking at the methimazole-induced remission rate in pediatric Graves' disease. And as you can see here, the remission rate on the y-axis and the treatment duration in the x-axis. And the overall remission rate was just under 30%, 28.8. And if you look at comparative studies, and there are 2 comparative studies here, the one in red is the recent study published by Aziz et al., and it compared the shorter or the standard 2 to 3 years or 2 years treatment to a prolonged course of up to 10 years of treatment. And you can see the success or the remission rate is much higher in patients who were treated longer. And this confirmed an earlier 2 French studies published in 2008 and 2010. So there is a shift toward using a longer treatment because it increases the remission rate. And these areas been discussed in the recent European Thyroid Association guidelines for management of pediatric Graves' disease. And the first line, and this is just a summary of what is in that guidelines. The first line is the prolonged course of methimazole, carbamazole for at least 3 years, and potentially you can go up to 5 years and longer, depends on the initial presentation. Avoid propyl thyroid, we know that. Preference for dose titration instead of block and replace, and this is based on the previous study I showed you. And if definitive treatment is required, you can use either the total thyroidectomy or radioactive iodine. Of course, radioactive iodine is not preferred for children under the age of 10. And surgery, we only use if we really have a very high or large goiter, or after a prolonged medical treatment or methimazole course with no remission. Now, before leaving thyrotoxicosis, let me just share with you this recent data published last year, and I think this is very interesting trial. It's exploratory trial in young people with Graves' disease, and it's basically just looking for the possibility or the benefit of adding rituximab, which is beta lymphocyte depleting agent. And we know Graves' disease is an autoimmune phenomena, and it makes sense to use anti-immune therapy for this condition. And the question the study asked was whether to use rituximab to increase the remission rate when given with a short course of antithyroid agent for just 1 year. It's an open label, phase 2, just not multi-center, but single arm study, 27 patients, which is good really for a pediatric population with Graves' disease. And they were given rituximab 5 milligrams, just 1 dose, and in addition to 12 months of antithyroid drug titrated according to the thyroid function test. And they stopped the antithyroid drugs after 12 months, and they assessed the patient at 24 months. And as you can see here, 48% of the patients achieved remission compared to the usual remission rate of 25%. In addition, the beta lymphocyte decline at 28 weeks was related to the likelihood of remission. So it is the rituximab which helped it in the remission. Carbamazepine dose also at 12 months were less than usual in the majority of patients, less than 5 milligrams per day. And the most important thing, there was no serious side effects. Now, the authors concluded from their work that the adjuvant rituximab plus 12 months antithyroid drug may increase the likelihood of remission, and they called for a randomized controlled trial to confirm this in patients with Graves' disease. And I think this is a new area in the management of thyrotoxicosis in pediatric age group. Now, let us leave the thyrotoxicosis aside and move to another area. And this is a 3.5-year-old boy who was born at 10 normal delivery, normal birth weight. He was noticed to have some developmental delay at the age of 6 months. Neurometabolic cause was raised. He was first child for his family. There's no family history of thyroid illness, and this is his thyroid function test taken at around the age of 6-7 months. And you can see the TSH was slightly raised, the free T4 a little bit low, but the free T3 was not measured. He was tried on thyroxine for nearly 3 months because the general pediatrician who saw him thought he had non-thyroidal illness or thyroid sickness, but he had no response. But by the time I saw him, he was scissoring here, and he's got severe hypotonia, and you can see here spastic quadriplegia. He was not walking or talking, and he's got myopathic face as evident by opening his mouth. But he has tachycardia of heart rate of 100, and he has no goiter. This is a thyroid function test at the age of 3.5 years. The TSH was slightly raised, T4 a bit on the low side, but T3 is above normal. And this child represents a typical picture of what we call Allen-Handem-Dudley syndrome, which is basically an X-linked recessive condition due to deficiency of the thyroid hormone transporter monocarboxylase 8. And the typical feature, they have slightly raised TSH, low or normal T4, but their free T3 is very high. And it's usually that the diagnosis is often delayed because these patients really don't present with a very distinguished or impressive thyroid function test. And this is just to try to explain what happened in this condition. This is the MCT8, which is one of the thyroid hormone transport, and specifically transport the thyroxine inside the brain. So if you have a defect here, you get accumulation of the T3 and T4 in the peripheral circulation, which can get inside the peripheral tissues, because they don't really rely on the MCT8, and you end up with brain hypothyroidism, leading to neurocognitive impairment. Whereas in the peripheral tissue, you have a state of thyrotoxicosis because all this T3 was accumulated in the circulation and T4, they will get inside the other peripheral tissues. Now, this is a rare condition, of course, but this is very nice data collecting just over 150 patients from 22 countries. And as you can see here, the patients, the majority of these patients, they were presented with gross developmental delay and hypotonia, similar to the patient I showed you. So it's not real. And if you look at the thyroid and normal thyroid function test, only the minority of them really were presented with abnormal thyroid function test. But they usually have subtle thyroid function test. And it is very clear here, if you look at the median age of onset of the symptom and the diagnosis, you can see clearly there is a significant delay in the diagnosis since the start of the symptoms. And we've seen it in this boy who was presented at the age of 6 months, and then the diagnosis was made at 3.5 years. So it's not really something unusual. Unfortunately, the majority of the 30% of these patients die during childhood, and the survival rate is very low as they get into the adult life. And most of these patients, the cause of death is unknown, and sudden death has been reported in up to 20% of these patients. Now, the bad thing is the treatment with conventional antithyroid medication is ineffective because you really need something that takes the thyroxine inside the brain independent of the MCT8 transporter. And this is a very nice study published just before the COVID era, and looking at the effectiveness and the safety of using the triiodothyroninic analog, which is TRIAC, in children and adults with this condition. It's an international single-arm open-label phase 2 trial, and you can see here patients ranging from 4 years up to more than 18 years. So they are combined adult and pediatric patients. And basically, the TRIAC is a substance that can cross the blood-brain barrier or can get the inside the brain cells without the need of the MCT8, and it's a thyromimic agent, more affinity to the thyroid hormone receptors, and it can suppress the TSH, and hence it can reduce the peripheral thyrotoxicosis, and it also can get you the thyroxine inside, or it can have some thyromimic action inside the brain cell. So in theory, it should work. And here, the effect of the 12-month trial, and you can see the serum T3 declined down, and this was associated by a reduction in the free T4 as well as the TSH, and was accompanied by good weight gain and resting heart rate improvement, i.e. improvement in the tachycardia. So it works in the peripheral tissue at least, and the best improvement when the triac was used, when the triac was started in early age, i.e. less than 4 years, because there is really still opportunity for this agent to work. Now, we know that it improves the consequence of peripheral thyrotoxicosis, but usually when you start using a new medication or a new way of treating any condition, you ask for long-term data, and this long-term data came just a year ago, and it is basically a study, a real-life retrospective cohort study looking at the patients who were in the previous trial combined with patients treated elsewhere outside the trial. 67 patients from 18 countries who were treated for up to 6 years. The median baseline age of the start treatment was 4.6 years, and they all have confirmed mutation in the SLC16A2. For this condition, the age range between little infancy, 6 months, up to 66 years, and these patients were treated for up to 6 years. The median age is 2.2, and it's basically if you look at the improvement achieved at 12 months in the previous study, continued to show both in the serum T3 and in the weight gain, as well as in the heart rate. So it seems that it works even on the long term. And this is the biochemical changes maintained, as well as the peripheral markers of the thyroid hormone action. And most important, again, there is no serious triac-related adverse effect reported in these patients. So it seems that this triac is safe and effective for the treatment of peripheral, at least peripheral features of the MCT8 deficiency. And there is still a trial undergoing to explore its benefit on the central or the neurological features. Now, I think if we have any pediatrician here, a general pediatrician, I'd like you to remember that if you have a child not walking or talking in your general pediatric clinic with a funny thyroid function test, please try to measure the free T3, because this is the hint for the diagnosis of this condition. Now, let me finish up with this 7-year-old asymptomatic boy who was found to have a high TSH on routine check that was repeated. 3 months later, remained high from 9.6, just dropped down a little bit, but the T4 is normal. And I'm sure you all know this is what we call subclinical hypothyroidism. He was not on any medication. He had no goiter, he's got normal growth, no family history of hypothyroidism, but he's got a very positive thyroid antibody in both TPO and anti-TG, and he's got normal lipido profile. And the question is always treat or not treat these patients. And I think this issue was addressed in the guidelines for the treatment of the American Thyroid Association treatment of hypothyroidism in children. And you can see here the treatment of clinical hypothyroidism in children is very controversial. And I think the same applies to adults as well. They suggested, this was 2014, they suggested that treat if the TSH above 10, patient symptomatic and high risk of progression to overt hypothyroidism. So, but there is no need to treat if the TSH is below 10 and the patient has negative autoantibodies, it's got idiopathic subclinical hypothyroidism, no goiter, asymptomatic, and they suggested a follow-up for the thyroid function test every 2 to 3 years if stable, and then follow them up annually and treat on individual basis. Again, another good review, a good systematic review, published in 2019, and suggesting that only treat the high-risk patients with high-risk progression to overt hypothyroidism, and these are the patients with hypothyroidism-related subclinical hypothyroidism who had TSH more than 10, again, positive antibody and associated syndrome like Turner or Down syndrome, and if they are prepubertal, if they have goiter or things. So this is just their suggestion. This is, I think there is a consensus on this one. Now, this is, let me end up with this nice review from the region, and this is published just 2 years ago, and it's basically trying to answer the same question. It's a very simple and good for general pediatrician to read. It includes the etiology. Of course, it is multiple etiology, and here I highlight that drugs, patients on antiepileptic, they tend to have subclinical hypothyroidism. We don't really need to treat them, and they split the subclinical hypothyroidism into mild and severe, and their conclusion was there is a consensus to treat patients with serum TSH more than 10 and normal T4, but the treatment of the TSH between 4.5 and 10 is uncertain and should be individualized. And they suggested to treat patients who are with mild TSH if they fulfill any of these criteria, which is whiter, high autoantibodies, syndromic, including non-Turner or Down particularly, or if they have genetic etiology for this condition, because there are some genetic mutations associated with subclinical hypothyroidism, and they develop later on into overt hypothyroidism, and if the patients have any changes in the thyroid gland in terms of swelling or nodules. Now, so in conclusion, the first line of management in pediatric Graves' disease is a prolonged course up to 5 years of carbimazole or metamazole. They're the same, depends where you are, using the dose titration regimen, and then adding rituximab to 12 months of antithyroid drug may increase the likelihood of Graves' disease remission. Triac appears to be safe and effective in the treatment of peripheral features of CT8 deficiency, but its benefit on the central features is unclear, and there is trial going underway. There is a consensus to treat children with subclinical hypothyroidism of TSH more than 10. However, treating those with TSH less than 10 should be individualized and has to be considered on based on the clinical criteria of a child. And with this, I'd like to thank you again, and thank you very much.
Thank you, Dr. Abdel Hadi Habib, for this nice and presentation. And just to remind you that this is the second annual Congress of Arab Thyroid Association, and we are on day 1. This is the pediatric session on thyroid disease. Want to go now to the third speaker, Dr. Najia Atiya, and she will give the last presentation in this session, and this will be followed by questions and comment. The Dr. Najia Atiya is a consultant pediatric endocrinologist at King Abdulaziz Medical City National Guard in Jeddah. Dr. Najia is well-known speaker, and she is also associate professor in the University of King Saud bin Abdulaziz in National Guard. And she will talk to us about pseudo-hypoparathyroidism. Dr. Najia Atiya, please.
Bismillah ar-Rahman ar-Rahim. Thank you for introduction, and I would like to thank the organizing committee for invitation and organization. My talk will be about pseudo-hypoparathyroidism, and this is the agenda for the talk. We are going to try to identify the etiology of pseudo-hypoparathyroidism, BHP, and also we are going to discuss the subtypes of BHP and how to differentiate between the different types. Diagnosis and differential diagnosis also we are going to discuss, treatment, complication, prognosis, and at the end we are going to present one of our cases. Pseudo-hypoparathyroidism, from the name pseudo, it means that parathyroid hormone is available but it doesn't work. There is a resistance to the action of parathyroid hormone. Normally, this is parathyroid hormone signals go through the receptor of the cell membrane receptors with the help of the alpha subunit, which is called the GS alpha. And this is subunits. It will activate adenyl cyclase to produce cycling A and B, a good amount for appropriate action of parathyroid hormone. But in case of pseudo-hypoparathyroidism, there is a gene mutation of GNAS, which encoding for this subunit, and this is actually lead to impairment of the action of the GSA, and at least will lead to a decrease also the activity of adenyl cyclase, and the production of cyclic A and B also will reduce, and this is lead to the resistance to the action of parathyroid hormone. And this is actually the main etiology of the most common cause of the pseudo-hypoparathyroidism. And actually there are many hormones join the same mechanism, and they need also this GSA. So because of that, the patient with the pseudo-hypoparathyroidism mainly have a resistance also to other hormones sharing the same mechanism. So you will find the patients also have resistance to thyroid hormone and resistant to LH, FSH, and GnRH hormones. This name pseudo-hypoparathyroidism, or the disease, discovered actually in 1942 by Dr. Feller Albert, who found that some patients have this high parathyroid hormone while the calcium was low and the phosphate was high. So what is the type? There are different types for pseudo-hypoparathyroidism, but the BHP type 1A is the most common subtype, and it is present in about 70% of the cases of BHP. And as you know, it is the same. There is a genetic defect in the GNS and decrease the production of cyclic A and B. And the mode of inheritance, it is autosomal dominant. But there is a very interesting in the inheritance way. I'm going to discuss it also later on, but the most important to know that the patient with type 1A, they have autosomal dominant mode of inheritance, and the way of transmission of the mutant gene usually should be from the mother. So the mother inheritance, it will lead to this disease, but if the mutant gene transmitted from the father, there will be only Albert hereditary osteodystrophy clinical picture, which we are going to discuss it. Epidemiology not well established because it is a rare genetic disease, and it is estimating just a prevalence range from 0.3 to 1.1 per 100,000 individuals, and it is depend actually in population studied, because for example in Italy they found that the prevalence about 1 in 150,000, and in Japan reached to 1 per 295,000. So it is really a very rare disease, with the estimation to be more common in females than males, about 2 to 1. The characteristic phenotype, how we can be able to diagnose this BHP cases based on clinical picture. As we mentioned, the A1 type A1 is the most common type of BHP, and they have actually a very characteristic phenotype. So you will find them, they are usually obese, and could be also short, and by looking to the hand, there is usually short of the fourth and fifth finger due to the metacarpal bone, shortening of metacarpal bone, and there is a dimple also of knuckles here. And if we did an X-ray, most likely we'll find subcutaneous calcification. All of this collection of clinical features also discovered by Albert, who discovered the disease BHP. But he found that not all of cases, they have this clinical feature. So they have named Albert hereditary osteodystrophy based on the Albert, he is an American endocrinologist, and he was specialized actually in metabolic bone disease. So named by his name, Albert hereditary osteodystrophy, and it found that this clinical pictures, it is found in patients with A1, type A1, and also found that when you give this parathyroid IV, there is a decreased urinary cyclic AMP production, and because of that, it is diagnosed pseudo hypoparathyroidism. Normally, when you give parathyroid hormone IV, as is in the blue line, there is increased the level of cyclic AMP in urine, but in case of BHB, either A or B, you will find that there is a blunted response and there is no increase in urinary cyclic AMP. And here just to about the inheritance mode, as we mentioned, it is usually maternal to have the resistance to parathyroid hormone in addition to the clinical features of Albert osteodystrophy, but only paternal from the father will found only the Albert hereditary. There is no resistance to parathyroid hormone if the mutant gene transmitted from the father. Okay, and this is the types. I found actually there are different subtypes for BHB, but I don't know, I feel it will be much better if I put it in the table, and how to differentiate between the types will be much better than if I give just a summary about each type. So let us to go together for, as we mentioned, this is type 1A, and we discussed it and we said that there is a mutation and there is a hormonal, multiple hormone resistance, and usually you will find it also thyroid, and you will find LH and FSH resistance. Albert hereditary osteodystrophy, yes, they have all the signs of Albert hereditary osteodystrophy, and the mutation, as we mentioned, it is maternal mutation of the GNS gene. And again, BTH infusion will lead to no response, and there is a suppression of cyclic AMP production in the urine, and there is no also decrease the phosphate in the urine. So there is a negative response to the BTH infusion. What about type B? How we can differentiate? If we look to the type B, we'll find the most striking features or characteristics that you will find also a resistance to different hormones, but the most hormone, 70% of cases of BHB type B, you will find 70% there is a resistance also to the thyroid hormone. Albert hereditary osteodystrophy, there is no signs, so they are clinically free. And there is a mutation defect also in the gene. There is maternal loss of methylation of the gene GNAS. And again, there is a negative response to parathyroid hormone infusion. So if we just how to differentiate between the commonest type A and B, we'll find that the most important feature for us as a clinician, that there is a resistance, there is a mutation, everything, but it's the difference that clinically patient has no signs of Albert hereditary osteodystrophy. What about type C? Type C, actually, it is more or less like type A. Exactly, there is multiple hormone resistance, and also there is Albert signs, and also there is no response to parathyroid hormone infusion. Only the difference genetically, if we did molecular genetic test, we'll find there is normal GS alpha activity. So in general, you cannot differentiate at all between A and C except by a genetic test. What about parathyroid BHB pseudo-hypoparathyroidism type 2? Type 2 will find the resistance only to parathyroid hormone, no other hormones, and there is no clinical feature of Albert hereditary osteodystrophy. Till now, the genetic defect not unknown, and when there is a good response to parathyroid infusion, but there is retention to the phosphate. Still, there is hyperphosphatemia and a decrease in phosphaturia by infusion of parathyroid hormone. So how we can differentiate actually between type 2. Type 2 and the type, for example, type B, it is difficult to differentiate except by doing genetic test, and we will find that it is unknown. There is no defect in GNS defect. And the pseudo hypoparathyroidism, this is very interesting, and it is easy to differentiate because you will find the patient have only signs of Albert hereditary osteodystrophy, as we mentioned before. If the mutant gene transmitted from the father, paternal mutation, will found there is no resistance. There is no resistance, normal parathyroid action and everything, just only the sign of Albert hereditary osteodystrophy, and everything normal, and there is no resistance to parathyroid hormone. So this is what is called pseudo hypoparathyroidism. So I hope by this explanation and tables, I try to just to make it easy, and how we'll be able to differentiate between the different types of pseudo hypoparathyroidism. Now we'll go to diagnosis. Diagnosis, actually, as we mentioned, it is BHP. It is a very rare disease, but important to diagnose. To diagnose pseudo hypoparathyroidism, we need a combination of characteristics and features and points to be able to diagnose. We cannot depend only on one test. So the most important, usually first, is the patient coming to us to just by examination, looking to the patient, and if the patient short, obese, and especially this is shortening of the fifth and fourth finger because of the metacarpal bone shortening. This is very important. And when we have this knuckle dimple signs, also to make it just clear by the pictures, this is raise the suspicious of pseudo hypoparathyroidism. And if we did an X-ray and they found there is a shortening of metacarpal bone, and if also lucky to found in the patient soft tissue calcification, this is increase the suspicious of pseudo hypoparathyroidism. And what about laboratory? Laboratory will find hypocalcemia, hyperphosphatemia with high BTH concentration. And this is figure just to tell us the relation between the parathyroid hormone and calcium. And as you know, with low calcium, parathyroid is high, and when the calcium increases, this will cause suppression of the parathyroid hormone. So there is inverse relationship between parathyroid and calcium. And I found this figure, it is really a very useful one. And it just explained to us the relation between the levels of calcium and parathyroid hormones in different disease. So here's the parathyroid hormone, and here's the serum total calcium. Normally, the green line here, normally, when the parathyroid hormone increasing, when the calcium losen, it will decrease and suppress when the increase of calcium and returning to normal. And in case of primary hypoparathyroidism, will found parathyroid low while calcium also low. And in case of primary hyperparathyroidism, will found parathyroid high, and it causes high calcium level. And in case of malignancy of hypercalcemia and the increase autonomy, increasing the calcium production. In cases of some malignancy, we will find calcium high, but there is suppression of parathyroid hormone. So this is figure also explained to us the relation between parathyroid and calcium in different disease. And what about our case here? What about the pseudo hypoparathyroidism? Actually, Okay, there is high parathyroid, hyperphosphatemia, hypocalcemia, but it doesn't give me immediately that the diagnosis of pseudo-hypoparathyroidism, because we need to, because of that, when we found such a condition, I said clinical picture, but some of subtypes of BHP patient completely normal, completely no clinical signs of Albert signs. So in such condition, it will be very difficult only to depend on the laboratory workup. So we have to consider some diagnostic differentiation when we have such a condition. So approach here, this is just approach to hypocalcemia. Why I brought it here? Because most of us will saw the patient coming to us with hypocalcemia, the commonest presentation. If we have signs of Albert, this is well and good. But if there is no signs, so we have to just do exercise and try to interpret the other hormonal assays. So let us to do here for hypercalcemia. If there is, we'll do parathyroid. All of us will do it, and it is low, so it is not a pseudo, but just to complete the picture. If you have low parathyroid hormone with the low calcium, think of primary hypoparathyroidism and the causes of it, or there is hypomagnesemia. But elevated parathyroid hormone, as in our condition now, there is a tip actually. A tip here to look to the phosphate. I advise usually this is what I am doing, to look to the phosphate levels, not to other alkaline phosphatase and calcium and all of this. It will disturb you a little bit, but let us to look to the phosphate first. And if we found low phosphate with high parathyroid, so this is maybe like vitamin D deficiency, pancreatitis, anti-epileptic medication, bisphosphonate, blood transfusion. Also, it is a straightforward differential diagnosis, and it is not our condition pseudo-hypoparathyroidism. But if the phosphate elevated or normal, here we'll put some differential diagnosis. Could be kidney problem, could be rhabdomyolysis, or could be massive tumor cell lysis. But in the differential, our condition, pseudo-hypoparathyroidism, BHP, it is here one of the differential and the possible diagnosis. So we'll look here if the patient kidney okay and no lysis of the cells. So this is BHP. Again, look to the signs, the clinical features of the patient. It is very, very important to us, especially look to the hand, short, obese, all of these signs you have to take it in consideration. And also mentality is important. So if there is signs of Albert hereditary osteodystrophy, so this is a case of BHP type A or type C, as we mentioned. And if there is no signs, completely the patient clinically free, so look to a resistance to thyroid hormone. If the patient diagnosed, for example, or primary hypothyroidism, so this is most likely BHP type B. Okay, but again, if there is no resistance to thyroid, okay, this is again could be type 1B or pseudo-hypoparathyroidism type 2. So I thought this is just a cascade or approach to hypocalcemia. For me, it is very useful, and try to reach to the diagnosis and not to miss a case. And also we have to consider vitamin D deficiency, because again, vitamin D deficiency, it is a common cause of patient coming to us with high BTH. Here, high BTH, we found it, but this is secondary. Secondary could be to vitamin D and not to the resistant to parathyroid. So we need also to do this exercise and be sure the patient not vitamin D defect, and not only deficiency. It is easy just to order vitamin D and they found it low because of intake, because of intestinal absorption problem, but could be vitamin D problem because of metabolism as hepatic problem, renal problem, genetic disorders, or drugs that accelerate catabolism, or vitamin D. Vitamin D defect could be due to defect in the action of vitamin D, and this is known in hereditary resistance to vitamin D. So when we try to diagnose pseudohypoparathyroidism, I know it is sometimes difficult because it is not all patients will come with the signs of Albert hereditary, and sometimes the patient come with the signs of Albert's, but still we are missing cases because we have to exercise ourselves about the signs of Albert hereditary osteodystrophy, and some cases are normal. So we have to utilize or do the approach to vitamin D, think of vitamin D problems, and think of the other causes of hypocalcemia. And this is trying to reach to diagnosis. If we have the facilities and we have the money, do genetic tests. This is the most important and the short way to diagnose. It will confirm the diagnosis, and it will be identify the types. But I put it at the end. Why? Because not all of us have the facility to do the genetic test. But please, if you think of pseudohypopara, do the genetic test, and you have the facility, do it. It will be confirming for counseling and for appropriate management. Management is a treatment. The treatment is a goal here to treat. Actually, we have to correct the calcium deficiency. We use IV calcium, of course, infusion or boluses as initial treatment if the patient presented with a severe symptomatic hypocalcemia. So we have to correct calcium. Maintain the serum calcium within the normal range. This is actually, it is very, very important goal of treatment to maintain calcium within normal range. Why? To suppress the BTH level to normal. And also from the goals to prevent the complication and to reduce morbidity. Medication, it is, although the disease is rare and important, but the medication, it is easy. Just try to give oral calcium as a replacement in cases of hypocalcemia, and we need to give active vitamin D, alpha calcidol or calcitriol, and because, as you know, parathyroid, it is not working. And because of that, we need to give an active vitamin D. In our hospital, actually in National Guard, we have calcitriol, but it is a tablet. So, and most of our children cannot swallow this calcitriol, so we are using alpha calcidol, which it is 1-alpha. And you need to monitor the medication, and just the monitoring of therapy, it is very simple also. Try to keep the parathyroid hormone and the calcium within the normal range. This is the most important. And also screening and the treatment for other endocrine problems. Defect, as we said, there are resistant usually to other hormones. What about surgery? Surgery, maybe we need surgery. If there's, rarely we need it if there is extraskeletal ostoma, which it is causes pressure on the important tissue. So we have to consult the surgeon and maybe need to remove it. Parathyroidectomy for patients with tertiary hyperparathyroidism, and this is the point which we don't want to reach to it. Tertiary hyperparathyroidism, that because the management was either delay or was not appropriate suppression of parathyroid hormone to the normal, and this is leads secondary to go to resistance to go to the tertiary, and in such a condition we need to do parathyroidectomy. About the complication of BHP, hypocalcemia as mentioned, and the carbopedal response with the patient may become with a seizure, also may become with ECG changes, and especially there will be a shortage of shortening of ST wave segment or arrhythmia. So this is an important complication. We don't want to reach to it because of hypocalcemia. Skeletal deformities, osteopenia, osteoporosis, and this is because of a resistance to parathyroid hormone, and this will lead at the end to increase the risk of fractures. Chronic kidney disease can happen from the long-standing hyperphosphatemia. So we need to avoid all of this complication by proper management. Neurological symptoms, some of patients come already with, especially type A1, they have them usually subnormal with developmental delay, seizure, because mainly from hypocalcemia. We need to avoid progression of this complication by adequate treatment and adequate counseling, attending especially schools. So we can improve this. And also dental problem from hypocalcemia and from the high phosphate also, and parathyroid hormone, and the tertiary hyperparathyroidism, as we mentioned. It can happen if we not treated the patient adequately, and we allowed the parathyroid resistance to go to tertiary. And this is complication. If you notice, most of it we are able to control it and to avoid it even by just appropriate management. What about the prognosis? The prognosis actually depends on the severity of the condition and the specific subtypes, because as we mentioned, some of the type, like the most common one, type 1A, the patient usually they have developmental delay with a cognitive impairment, and other types, or if there is no clinical signs of Albert, they also depend on how much we able to control the bone disease. So they will come with a more severe bone mineralization, fractures, deformities, and so this is actually depend on the severity of the condition and the management early of such cases. However, with appropriate treatment and management of metabolic abnormalities, bone problems, many individuals actually with BHP can have a healthy and very productive lives. Because as we discussed it before, most of the complications depend on the appropriate management and appropriate follow-up. Now, and finally, I will discuss one of our cases. Actually, we reported it 2021, more than a year ago, in International Journal of Endocrine and Metabolism. This case, actually, it is an interesting case. Khalid, he was 9 years old when referred to our clinic in National Guard Jeddah, and he came to us because an inability to extend his right elbow, and also because of obesity. When you go to the history, we found that there was a swelling in the right elbow noticed by the family at age of 2.5 years, and which was followed by movement limitation of the right arm, but there is no history of trauma. And at 9 months of age, the case diagnosed in other hospital as primary hypothyroidism and started on treatment. He is a product of full-term normal birth weight. Parents were consanguine first degree, but no similar condition in the family. By examination, when you look to Khalid, he has a normal height, but he was obese. BMI was 37.6. And when you look to him, also we found that there is a fixed flexion of the elbow, and by palpation of his forearm, we found there is like masses, several masses. You can feel it when you examine his hard masses, when you examine his right forearm. And his looking to the hands, hands were symmetrical with just increase the pigmentation of knuckles. And by doing the lab, here the calcium was normal, phosphate was high, alkaline phosphatase normal, parathyroid was sky high, about 4 times high, vitamin D was a little bit lower than normal. So we did actually X-ray just to make it, because when we look to the lab, as we mentioned before, maybe the only striking feature, let us to return back to here to the lab. When you look to the lab, actually, to interpret, for me, I will find parathyroid hormone high, while phosphate also is high. So this is the tips we mentioned it before. This is actually also increase the suspicion of pseudo-hypoparathyroidism. But to be honest with you, the clinical picture also, it was the first flag to us to think of BHP. Also, the second was the lab. And when we did the X-ray and we found this subcutaneous calcification, which was really severe and extended everywhere and even mixed with the bone. So this is for us confirm a case of BHP. And we did a genetic test because it is available, just to be very sure. And we did it actually, and there was a mutation in GNS gene. And by this way, we know, confirm it, a case of BHP type 1A. So after diagnosis, parents were extensively counseled about the mode of inheritance and about the prognosis and about the treatment and the important for follow-up and to continue taking the medication. And further evaluation, we did also a brain CT and echo to look for other site of extra osseous calcification. On follow-up, we found the patient, actually, he came to us, the calcium was normal, but according to the family, he was not in calcium. But with time, the calcium levels were low, and we added calcium to alpha-calcidol. And skeletal examination, actually, when we follow the patient, we found that it was the calcification extended more, and it was progressing more. At this point, I was, to be honest, I was a bit thinking, scared a little bit, because when I examined, I didn't have a picture, but when I examined his fingers, I found it a little bit blue. So I thought maybe there is a compression on vessels, or it is we reach to a dangerous stage. So we did actually a multidisciplinary meeting, included us as endocrinologists and geneticists and pediatric orthopedic and the vascular also, and we discussed the case thoroughly. But according to them, there is still no active medical treatment to resolve any established subcutaneous calcification. And even I was a little bit shocked, because when we discussed it with during the meeting with the orthopedic, he said it is very, very difficult to remove this this soft tissue calcification, because according to him, and he explained it to us, actually the calcification already entered to the bone and already as united with the actual bone, and it is very difficult to separate it and to remove it. And according to him, just to follow up the condition, and if we reach to a severe case that the patient cannot move his hand because it becomes completely solid and very difficult to work or to move with it, we will do amputation. The question actually regarding this case, could this patient be diagnosed at an early stage or early age? Rarity of the disease is very important, actually, and maybe it is also contributed to delayed diagnosis. In addition to that, subcutaneous calcification also is rare in childhood, and this also contributed to delayed diagnosis. Clinicians don't commonly evaluate obesity when it is not severe, and this is also a contributing factor. Seem to be in this condition, the physician focused mainly on the fixed flexion deformity, and so this is maybe also it is important to take it in consideration. Lack of family history, all of this could be also contributed to delay diagnosis. However, development of hypothyroidism in this condition at 9 years of age, followed by a hyperparathyroidism, should raise the suspicion of Albert hereditary osteodystrophy. Also, obesity was a part of the syndrome, but was not taken seriously, hence it was not evaluated thoroughly. Also, ectopic calcification itself might raise a flag of Albert hereditary osteodystrophy, and all of these points we should take it in consideration. So the key points actually, BHB is a rare genetic disorder that affects the body's ability to respond to parathyroid hormone, subcutaneous ossification, and brachydactyly, short stature, obesity, all of this associated with BHB. And molecular genetic or epigenetic testing is advised if it is possible. And appropriate diagnosis and treatment should be minimize any complication, as we said it before. And the care is multidisciplinary for children and adults. Maybe increase awareness about the BHB may be needed because it is, as we mentioned, it is a rare disease. And as we discussed it, our patient came late to us at 9 years of age. Thank you and for coming.
Thank you very much, Dr. Najia, for this presentation. And by the end of this session, I would like to ask the three speakers to join now for questions and for comments. Dr. Rasha Tarif and Dr. Abdul Hadi Habib and Dr. Najia Atiyah. We would like to probably go through some of the questions which came to us from the audience. And maybe I start with the first question here for Dr. Rasha Tarif. Dr. Rasha, the question is about persistent TSH in children with congenital hypothyroidism. The question came as some patient we treat as neonatal hypothyroidism, and despite adjusting the dose, the TSH continue to be higher than 10 units per liter. What should we do for this kind of group who, despite you go with the normal range or the high range, they still have high TSH? Dr. Rasha, please. Dr. Rasha, are you with us, Doctora? Maybe I'll go to Dr. Najia Atiyah. Dr. Najia, I have some questions about the pseudo hypoparathyroidism, and one question actually came as for the should any patient, child or any patient come to us with subcutaneous calcification investigated for pseudo hypoparathyroidism?
Thank you for the question. I think yes, we should do, because it is very rare to find subcutaneous calcification in children. So it's worth it to investigate for parathyroid, thyroid, and resistance, because you can, as we mentioned, you can save a lot of comorbidities and a lot of complications by simple test.
Thank you, Dr. Najia. Another question came, Doctora, is if we have patient with manifestation of low calcium and high parathyroid hormone level, and come with, similar, maybe should we treat him first with vitamin D and then wait and see if he responds, or diagnose him as pseudo hypoparathyroidism?
No, exactly as you mentioned. We have to rule out the secondary cause of high parathyroid, especially low calcium and low vitamin D, because this is more common than just resistant to parathyroid. So if any patient came with hypocalcemia, try to know the cause of hypocalcemia, of course, and treat the patient with calcium and observe if the parathyroid started to be coming down. So this is a simple case, and it is not a resistance. Also the same with vitamin D, because it is a common cause and of high parathyroid.
Sure. Thank you very much, Dr. Najia. I think the first question which I raised in the beginning about the permanent, what we call it, permanent TSH elevation in patient with congenital hypothyroidism, I might probably give the answer that if this came actually from Dr. Anura, if the TSH during treatment of congenital hypothyroidism continue to be elevated, despite that you kept the free T4 in the high quarter of the normal level, because we like to keep the level in the high quarter during the treatment, especially in the first 6 months or 1 year. If the TSH could not come down and by below 10, I think you can accept it. And this is what we call due actually to the in utero exposure of the thyroid axis to be high TSH. So you can accept it. Don't give higher dose of L-thyroxine to overcome the TSH, because if you do that, you might prematurely close the sutures of the skull, and this might cause a problem in the baby where the brain is developing and the skull might develop abnormal shape. So I think this is known phenomenon that sometimes you might accept slightly elevated TSH. Sure. I think if there is no more questions, I will stop here. I would like to thank you, Dr. Najia, for this nice presentation on pseudo hypoparathyroidism. I would like also to thank Dr. Rasha Tarif for her talk about congenital hypothyroidism, and for Dr. Abdelhadi Habib, who gave us hot topic in thyroid disease. And I would like also to thank the director of this conference, Dr. Nasser Al-Jahani, and his group for organizing this for the second year. Thank you very much. And we'll see you again, inshallah. Thank you.
Thank you.